Improving length of stay by targeting specific care units is our episode topic. My guest is Kamela Kolander, a social worker by background and consultant with BRG's Care Transitions team. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Cam, thank you so much for joining us today.
Thank you so much for having me.
Before we get into our episode topic today, can you tell us a little bit about yourself?
I started off my career as a social worker at a hospital in the ICU unit, in an observation unit, and in the ER, and loved doing case management, discharge planning. I went into then liver transplant. I was a financial business coordinator for liver transplant and did case management with that as well, and then got into management. I was a manager for care management and then a director, and I love working in the hospital, discharge planning and helping people.
This episode is the continuation in a series we are doing looking at various targeted strategies hospitals can use to improve their lengths of stay for both admitted inpatients as well as those in observation status. In Season 4, Episode 2, Lowell Harden laid the foundation by discussing how to prepare your frontline leaders for success in both leadership and change management. Then in Season 4, Episode 7, David Broussard discussed targeting specific units as a strategy to improve length of stay. Coming up in Season 4, Episode 11, Caroline Segovia Marquez will discuss targeting lower case mix index DRGs as a strategy to improve length of stay. This episode will discuss targeting specific care units as an effective strategy to reduce length of stay. With that in mind, why is evaluating length of stay and targeting specific care units an important strategy?
So I think it's very important. Like each hospital is very different. So looking at where the hospital is located, the sizes of the hospital, if it's a small hospital or if it's an urban hospital, it's important to just take all those factors into consideration as well as payer mix. If you have a hospital that has a lot of uninsured patients or a heavy Medicare population. So it's good to evaluate it, see what you're going to get into with length of stay and any barriers to that. Also, with the different post-acute facilities that are around the area, if it's a hospital in a smaller town that doesn't have a lot of post-acute facilities, that will also extend your length of stay trying to get those patients placed. So just doing a big evaluation, a quick evaluation of the setting of where the hospital is located within the hospital, again, with payer mix, population, patient demographic. It's just important to do that before you dig into the unit-specific barriers that you might be facing.
How do you know what units to focus on? Because a length of stay for a patient being admitted with pneumonia is very different than a length of stay on a patient being admitted with a knee replacement.
Data is your friend. So it's very important to use the data that you have in your hospital. If it's a length of stay dashboard, looking at that data and trying to drill it down per unit and see where your excess days are for those units. And I would take the top 3 units that have the highest length of stay or excess days, and then really drill down to that for where those patients are going. Are they going to a SNF? And is that a section that you need to look at? I would even drill it down by payer and by provider. So using data to look at, okay, within the hospital, which units do I need to focus on? So that's where I would start, is really using your data to help uncover those issues.
Now, you mentioned excess days. In a previous podcast, we had your colleague David Broussard when we were focusing more on the provider side, and he was talking about O to E ratio. Are we accomplishing the same thing regardless of which metric we're using, or is there a better strategy here of do I focus on O to E, or is it excess days, or are they just different way of counting the same thing, which is long lengths of stay?
Yeah. So for the O to E ratio, I think you want to look at everything. You want to look at the O to E into the excess days. Anything over that GMLOS is an excess day. So when you're looking at units and you're drilling down, say a patient came in, like you said, with pneumonia and has an excess day of 3 or 4 days. So what's keeping them there that long? And so you can drill that down again, like I said, with DISPO. And if the patient needs to go to a SNF, is the SNF process, are your case managers getting in and talking to that patient day of discharge, asking them what their resources are? If they have a SNF that they want to go to, are they giving that patient a long time to pick that SNF? So you can drill it down that way with excess days. And then the O to E ratio, looking at that in a more broad way, it's okay, this patient on this unit O to E ratio within for the whole hospital is not hitting that 1.0 mark. It's 1.5. So what can we do as a hospital?
All right, so I'm a chief nurse executive, I'm a chief nurse officer, I'm a director, and I'm trying to understand where are my problem units, where are my high length stay units, and I've identified that 4 Main is my unit that I really want to start tackling on. They've got a really high number of excess days compared to the other units where I'm operating. What's next? What type of intervention should I be using for this specific unit,
Okay.
given the fact, understanding that they're not performing where we would like them to perform with respect to length of stay?
Yes. So I would look again, I go, so where are those patients going? If you have a high population that are going home, most hospitals with care management, let me just back up a little bit. They have different roles, social workers and nurses. Some hospitals have both roles, the social worker and nurses doing the same thing in discharge planning. Some hospitals have nurses that are doing more of the post acute discharges and social workers doing hospice. So I'd first see, okay, now what is your role for those social workers and nurses? And is that unit, do they have the appropriate staffing? If that unit has the majority of the patients discharging to a skilled nursing facility, and their nurses are supposed to be discharging those patients to a skilled nursing facility, do they have enough nurses on that unit compared to social workers? So that would be my first staffing mix. And on the flip side, if they're all going home and they need more psychosocial, more social needs, and your hospital is set up in that way, do they have enough social workers on that unit? My first intervention is making sure staffing is appropriate for that unit.
Yeah, let's talk a little bit more then about psychosocial. You mentioned that if there are psychosocial needs, then maybe social workers are the appropriate approach from a staffing perspective. So, based on your experience as a social worker, what are some of the interventions that you look at specifically to address those patients that have psychosocial needs to help with length of stay reduction?
For example, in the ICU, making sure that you get in and talk to those patients and families about a care plan, doing family meetings, making sure they know the expectations, even in the ICU, that they know the expectations that eventually patient will discharge. So I've done family meetings, patient contracts too, bringing everybody involved, if it's financial coordinators, social worker in there, as well as the case manager. One thing that's important with social worker and nurses is proactive initial assessment. So addressing their needs, their discharge needs, as well their psychosocial needs too, especially with social determinants of health being so important now. CMS requires that you do an assessment to determine those needs. I think that's very important, just addressing those needs up front, as well as having an avenue to connect that patient with services for those needs. If it's transportation, if it is food resources, a good tool that I've used in the past is called Aunt Bertha. And so it's just a tool that you can go in and you can connect those patients with different services in the community that they may need. So the most important thing is just identifying those needs in the very beginning of the hospitalization.
How do you know that addressing length of stay on specific care units helped improve the overall hospital length of stay and patient throughput?
Monitoring your data, making sure that you continue to monitor your data on a consistent basis. Again, like I said a couple minutes ago about the staffing mix, hospitals get overwhelmed and patients have to go to different units. So making sure that you have the correct staffing and always monitoring that data is important to know if you're doing good, if you need to recheck and change the way that you're looking at the data. Also, the
So
reduction.
what frequency should we be doing this? Monthly, quarterly, daily, weekly?
Definitely monthly, if more at least monthly, you should have monthly scorecards that go out to your units. Leadership should know their data daily, but I think for the team, they need to know if there's a dashboard, I would say leadership needs to look at that on a daily basis. The team needs to at least see that data on a monthly basis, know where they are with length of stay. I think it's so important for the team even for the team to bring up opportunities of how they can change length of stay, things that leadership might not understand or realize at that point. So I think it's very important to look at the data consistently. Things change in a hospital, even with where the patients are going at discharge. If there's issues with post-acute providers, I think it's important to look at that dispo. If you're seeing a long length of stay of getting these patients to a post-acute providers, making sure you have conversations with those post-acute providers and seeing if there's any barriers that can be addressed at that point. Also, care management can collect avoidable days per unit and see if there's any issues.
What is an avoidable day?
So testing. So say a patient needs to go down and get an echo and they weren't able to get an echo for 2 days. So that delays the patient from discharging. And so that would be an avoidable day. If a doctor goes in and says, hey, you can stay another day, but the patient's ready for discharge, that would be an avoidable day to the physician. If the family is saying, oh, no, I'm not going to discharge, I don't want to discharge, I don't want to pick a sniff, that could be an avoidable day to the family. And so the director, the manager of the department can look at those avoidable days and see if they can put process improvement. You'll see a lot of avoidable days with insurance off. If it's taking longer than the time period insurance says that they will get back with the authorization, that can be an avoidable day to the payer. And then you can look at contracting for payer issues. So those avoidable days are important to look at and see if you can put process improvements around those days. And so in the beginning, you might collect a lot of avoidable days. And then once your team gets knowledgeable of putting in the avoidable days, addressing the avoidable days at the end, you shouldn't have as many. So you can also know that you're improving your length of stay when there's not as many avoidable days on your unit. So it's just an avenue to kind of address barriers and address length of stay.
Any closing thoughts as we wrap up this episode?
Possible leadership is so vital and important to support the care management team to address length of stay. It's important to engage the team on a unit level, again, to ask them what they're seeing on their units as far as barriers. Also, data transparency, making sure that the team understands length of stay, excess days that they have on their units. The providers understand their data and are looking at their data as well. And then team collaboration, making sure working together to discharge those patients on a timely basis. And then just ongoing process improvement. It's ongoing. You always have to look at length of stay and what you can do to shorten that time.
Improving length of stay by targeting specific care units has been our episode topic. Cam, thank you so much. Appreciate your time today.
Thank you so much.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.